and welcome to the Alabama Public Health Training Network. Thank you for joining us for our program, Ebola, What We Know Today and How We Can Prepare. Our objectives today are to discuss current knowledge about Ebola virus transmission, signs, symptoms, risk for the United States, diagnostic protocols and treatment, review personal protective attire, equipment, and provide references for additional information. Summarize hospital preparedness, environmental measures, along with providing references for additional resources, and provide awareness of Alabama's public health training process, availability of resources such as algorithms, specimen, laboratory instructions, and ongoing development of materials for Ebola. If you have a question about anything being discussed today, please call or email our faculty presenter during our live broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, handouts and the link where you can complete the activity evaluation for this program are available online at the website on your screen. Continuing medical education credit has been provided for today's program. In order to receive CME credit for this program, you must watch the entire program, then complete the electronic evaluation activity. Please note the University of Alabama School of Medicine and the Division of Continuing Medical Education are committed to the provision of CME that is balanced, objective, evidence-based, and free from the control or influence of commercial interest. We strictly adhere to the Accreditation Council for Continuing Medical Education's essential areas and their elements, including standards for commercial support. Accordingly, all persons in a position to control the content of this educational activity have disclosed all relevant financial relationships, and any conflicts of interest have been resolved. I'm Dr. Karen Landers, pediatrician and area health officer, and with me today is Dr. Albert White, infectious disease physician with the Alabama Department of Public Health and Public Health Area 3. Welcome, Dr. White.
Thank you, Dr. Landers. Well, good morning to all of you out there. It's a pleasure to be here today and participate in this important program. As we all know, Ebola is an infection that is now a very big concern for us, and we're hoping that the information we share here today will be helpful to all of you. This disease causes a hemorrhagic fever. It was first identified in 1976 in Zaire near the Ebola River when there was an outbreak there. Since then, there have been several outbreaks over the years that have led to the current outbreak that we are experiencing. It is caused by a virus known as the Ebola virus. There are 5 subspecies of this virus, 4 of which are known to cause disease in man. The current outbreak in West Africa is the largest Ebola outbreak in history. It's the first outbreak in West Africa, and it has been declared as a public health emergency by the World Health Organization on August 8th of 2014. Currently, there are several countries that are experiencing this outbreak, and they include Guinea, Liberia, Sierra Leone, Nigeria, Senegal, and now a case has been diagnosed in the United States. The case fatality rate of the current outbreak in West Africa is around 70.8%. The outbreak started again in Guinea back in March of this year, and this is a close-up of the area in West Africa where the disease is prominent. You can see the red spots on these dots and the other areas where we have treatment centers or so, but it is spreading in these areas, and it's going to continue to spread if things are not done in order. The total number of cases identified up to September 23rd, and this is thought to be an underestimate of the total number of cases. They are now over 6,500. The total number of deaths in those countries in West Africa is above 3,000. Liberia is the most hardest hit country right now, experiencing over half of these deaths identified. The difficulty in controlling the disease in West Africa is multiple. There are several reasons. Several of the countries in West Africa have gone through a devastating civil war within the last 10 years, and their health infrastructure is very poor. There's mistrust of the system, the healthcare delivery system, and people are not coming to these centers. There's increased death in healthcare workers, and that makes the people think about, wow, if the healthcare workers are dying, then we have very little chance. They hear the message that there is no cure, and so they avoid the treatment centers. Contact tracing has been a nightmare, and it will continue to be a problem and the cause for the continued spread of this disease. There's inadequate education in the use of personal protective equipment and infection control practices. The cultural habits in these areas regarding the burial of the dead bodies and practices, it also is a prime way in which the infection is spread. The handling of potentially infected animals also is known to be a problem. These are some of the healthcare workers that have died in the countries in West Africa. Dr. Motoro is a Ugandan physician who worked in Liberia. He was the first to die in Liberia. Dr. Khan is from the Sierra Leone. He died. Dr. Adedivo is from Nigeria. She was one of those who was exposed to the traveler from Liberia, and she also succumbed. Dr. Abraham Bobo, the assistant medical director for the JFK Hospital in Liberia, also died. Father Miguel Pajares in Liberia at the St. Joseph Catholic Hospital, he died. And Dr. Samuel Brisbane. Dr. Brisbane was a person who I worked with when I worked in Liberia, and we were very close to his family, and he died. So this is very close to my heart. Healthcare workers serving in Liberia who contracted Ebola and was brought back to the United States are Dr. Ken Brantley, who we all know about, and Nancy Wrightball. They both have survived Ebola, and they're doing well. Since then, there have been several others Westerners who have contracted Ebola and have been evacuated from the region, and they are currently in hospitals here. The incubation period for Ebola has been known to be between 2 and 21 days. Most people who are exposed will get sick during that time period. It also depends on how significant the exposure is, whether you get sick early or whether you get sick later in the course of your illness. The symptoms of Ebola include fever, usually greater than 101.5 degrees Fahrenheit. People get severe headaches, they get muscle pain, they get weakness, they get diarrhea, they get vomiting, they have abdominal pains, they lack of appetite, and several of them have unusual bleeding. There was a paper published in the New England Journal of Medicine recently that summarized the first 9 months of the Ebola outbreak in the region. And the first 5 symptoms that, according to how they presented there, included what I just mentioned. Again, fever being in over almost 90% of the patients, fatigue, lack of appetite, vomiting, and diarrhea. People do recover from Ebola. Again, not all people die, and the best chance of recovery is if you went to a treatment center where you get good hydration, where you get antibiotics, where you get other things that will support you. And people who do recover from Ebola, they do not get the infection again. And many of these people are now contributing to helping to care for Ebola victims in the region. It is suspected that the immunity will last for up to 10 years if you recover from the disease. How is Ebola spread? It's spread through direct contact through broken skin or mucous membranes. From person to person, someone has to be ill before he can or she can spread the virus. And it will come through their blood, the urine, saliva, feces, vomitus, or other body fluids. It can also spread from the surface to a person. If there are objects such as needles or that are contaminated with body fluids, you can get it from there. Animals to person also has been known, especially in wild animals and bats that have been seen to transmit the disease. Ebola cannot, and I say it again, cannot be spread by air, by water, or by food. It is not an airborne illness. My plea to the people of Liberia, Sierra Leone, Guinea, and Nigeria is, please regard this Ebola problem seriously. Please seek medical attention if you become ill. Do not hide sick people in your homes. Please cooperate with authorities about not traveling when you are sick or going back home to the village when you are sick. Don't touch blood, urine, or bodily fluids of anyone who is sick. Go to the quarantine areas if you know you have been exposed. And please let the authorities take care of the dead bodies and bury them. My plea to the healthcare workers in the region, I said, please take this infection control practice seriously. Please learn about the disease and how it is spread. A little bit of bodily fluid from an infected person can infect you if you come into contact with it from your broken skin or your mucosa. Please learn how to put on and take off the personal protective device equipment correctly. These measures will help protect you and your colleagues and your patients who are in quarantine who are not yet infected. Please think about other conditions that can mimic Ebola, like malaria or typhoid fever. I thank you all for putting your lives at risk and for the hard work that you continue to do in the region. God will bless you. Now, CARE's definition for Ebola, we have several presentation on different websites about who we suspect to have Ebola. These people are people who have consistent symptoms and have specific risk factors. One, they have to have the clinical criteria and symptoms like that we talk about, the fever, the headache, the nausea, and all of that. And they must have the epidemiologic risk factor of having been in an endemic area within the previous 3 weeks. These are the only people who will consider to have Ebola. Sometimes I've heard people call the hospital or the health department and say that they have come from Mecca or something and they want to know if they could have Ebola. Well, people in Mecca don't have Ebola right now. What is the CDC doing towards trying to control this outbreak of Ebola? It has activated its Emergency Operations Center at Level 1 to help coordinate technical assistance and control activities with partners. The CDC has teams that have been deployed to the affected countries to assist with response effort in surveillance, in contact tracing, in data management, laboratory testing, and in health education. Updating communication products and web pages with new information for the general public and specific audiences. The CDC's web page has a ton of information. It's the www.cdc.gov. The Ebola page is on the front page, and if you click on that, they will send you to different places that you can find a lot of information. They're actively working to educate the United States healthcare workers on how to isolate patients and protect themselves from infection. Again, those resources can be found on the website. Currently available guidance exists for infection prevention and control recommendations for hospitalized patients with known or suspected Ebola hemorrhagic fever in the United States. It's a lengthy document. It has a lot of points. Some of them we will go over during the course of this presentation. There are interim guidance for environmental protection control in hospitals for Ebola patients, for the Ebola virus. There are interim guidance for specimen collection, transport, testing, submission for persons under investigation for Ebola virus disease. Again, all of these guidances can be found on the CDC website. There is also instruction about the safe management of patients in the United States hospital. There's guidance for flight crews, emergency medical services at airports and customs and border protection for reporting sick travelers. What is the Alabama Department of Public Health doing? We have established an interdisciplinary group that is specifically assigned to task for developing resources for Ebola. We have communicable disease group people, the epidemiology, emergency preparedness, we have nursing, we have pharmacy on that, we have emergency medical services, communications department, our legal and dental services. We've had several meetings and several documents have been prepared that is on the Alabama Department of Public Health website, and that website is www.adph.org, and you /Ebola, and you will have a lot of information there for you. We will go over a few of the information that are found or available on the CDC website and on our website now, again, just to highlight those things. The Alabama Department of Public Health, we have a fact sheet that we have developed, and it answers questions like, what is Ebola? What is my risk of getting Ebola? What are the symptoms of Ebola? How does Ebola spread? How do you stop the spread of Ebola? And what is the treatment for Ebola? Again, the treatment for Ebola, there is no specific antiviral for Ebola at this point. It's mainly supportive care. There have been some experimental treatment that have been given to some of the individuals who have there, but the majority of the treatment will be supportive care, fluids management, and other basic medical services. And where we can find this information, again, is at the ADP-ish website. ADP-ish information for if you have consumers out there can call this emergency preparedness number 1-866-264-4078. Now, when you have a case that has been suspected or someone who meets the criteria that we have for the Ebola virus disease, we are asking you to report that to the health department immediately. If a person travels or comes from an infected area and have symptoms that suggest the Ebola virus disease, there is an investigation form that is on our website, and we'd like for you to go there, find that form, familiarize yourself with it, and fill it in, and as you talk to us to help us determine whether this person is someone of interest or not. The Ebola virus disease screening, again, you have to talk about, can I get this picture here? Right, thank you. Ebola virus disease screening, again, you need to have someone who has a fever, muscle or joint ache, fatigue, vomiting, and it's important, this person must have traveled to one of these areas, in Liberia, Guinea, Sierra Leone, or other countries where EVD has been reported within 21 days. If these criteria are met, the patient needs to be placed in a private room with a bathroom and standard contact and droplet precautions started, and immediately contact the health department so that we can work up and find out some more about whether this patient is a patient of interest that needs to be tested. The Ebola virus screening consultation record, again, is on our website. There are several pages of them. It has the identifying information on the patient, where they've traveled, whether they've been in contact with someone who was sick there, whether they participated in burial, whether they went to a funeral, any of those things. When we fill these things up and they have the clinical symptoms, if they're a person of interest, then we will be given instruction about how to collect specimen and where to send the specimen. Again, these forms are available on the ADP-ish website. That's adpish.org/Ebola. And under the healthcare worker portion, you will find these forms. They are made available to us. There also is a self-monitoring chart there that for patients who, again, have not gotten ill, but they have traveled to this area and they have come back here. Those patients, they need to monitor themselves for the next 21 days to see if they get ill. If they are household members, too, of someone who has been identified with the disease and they're not ill, this is another self-monitoring chart that we'll need to be familiarize ourselves with it. The patient's primary care physician or their medical provider, along with public health, will assist in having this form filled out until the time of suspicion is over. So these were the forms that I just went through, showing you what they are. We also have, here is a very busy slide, but it's an algorithm of what we can use if we suspect that someone has been exposed. There are people who are high-risk exposures, there are some who are low-risk exposures, and some who've had no exposure at all. And this form can be downloaded from our website, and it helps you to go through the different options about when someone would need to be tested or when you need to, get in touch with CDC or with the Alabama Department of Public Health. This is very important. Thank you. Now, are U.S. hospitals ready for patients with Ebola virus disease? The answer is yes. Any United States hospital that is following the CDC infection control recommendations and can isolate a patient in a private room is capable of safely managing a patient with EVD. I know there was questions and concern earlier when Dr. Brantley was brought back to the United States and was at Emory and was in this high-level containment area. People were wondering in local hospitals, well, we don't have that kind of facility. How can we take care of this patient? But now we're seeing with the identification of the patient in Texas, that hospital there is able to isolate this patient and begin to manage this patient. Are hospitals ready to care for patients with Ebola virus disease? CDC recommends that the United States hospitals isolate the patient in a private room and implement standard contact and droplet procedure. We do have, again, on the website, a detailed hospital checklist for Ebola preparedness. And I found this document to be very helpful. It's going to help us to detect, protect, and respond appropriately. Our local hospital in Tuscaloosa, Alabama, we've gone through and looked at this checklist, and it has a lot of questions in there. And the questions, you should mark whether the event has been completed, whether it's in progress, or not started. This will help you to know what all you need to do in order to get your hospital and your facility ready in the event that you will have someone with Ebola there. I strongly recommend that you look for that form, download it, and it will tell you whether you are ready for it, and the places where you're not ready yet, and then you can begin to have some communications with your folks, with your local health department about getting those things ready. Things like having triage, how to triage people in the emergency department. I mean, it is so key. One of the first things, if someone comes in there with headache, or so, you need to be asking, hey, have you traveled to any of these regions within the last 21 days? And I'm telling you, it will happen sooner or later that someone will show up at your door. And I say so because it had happened to us in Tuscaloosa already. Fortunately, the patients who had traveled in these areas did not have signs of Ebola. They had not been exposed to any sick person, and we found alternative diagnosis in these patients. They had malaria. So please make yourself familiar with this checklist on our website. Interim guidance for environmental infection control in hospitals for Ebola. This is another big document that the CDC has put out, and this, I think, infection control issues and environmental control is very important in how we manage patients if they show up. Be sure that your environmental services staff wear the appropriate recommended personal protective equipment, including a minimum, disposable gloves, gowns, fluid-resistant gowns, eye protection, goggles, and all of these things. I want you, again, to please familiarize yourself with these interim guidelines. Look at them, read them, get your infection control person to look at them, and to be able to see if you have these things. Additional barriers like leg covers or shoe cover may be necessary if there's a lot of vomiting and stuff on the floor while you're taking care of some of these patients. Be sure that your staff are instructed on the proper use of protective equipment. Again, this is an opportunity for hospitals around the country to just review what you do. We all have patients who are in these contact isolation things now, contact, droplet, or airborne, and we need to have these things available to wear. It's time now to start making sure people can take them, put them on correctly and take them off, because if you're taking care of an Ebola patient and your gloves or your gown gets contaminated with their secretions and you don't take it off correctly and you inadvertently touch it or get it to your eye or so, you will be at risk and your chances of being infected is very high. This organism, this virus, it is very infectious. Small amounts of it can cause an infection. And again, we talk about being prepared to isolate the patients, putting them in a single room, and making sure that they have a private bath and doors closed. That document, again, is very big, and I tried to summarize some of the high points of what they talk about, and please, again, make yourself available. If patient in a U.S. hospital identified to have suspected or confirmed EVD, which has happened, what infection control precautions should you put into place? Again, we talk about restricting visitors, avoid entry of visitors into the patient's room. Exceptions may be made. A logbook should be kept, documenting all patients entering the room. See the CDC infection control guidance on procedures for monitoring, managing, and training of visitors. We also recommend to avoid aerosol-generating procedures on these patients, because if you do, then you're going to the regular mask will not be appropriate. You have to go on to the N95 mask. Again, these patients, just for the regular treatment in the hospital, they do not need to be in airborne precautions. They just need to be in a private room with standard, with droplet, and contact precautions. There are a couple of graphs or cartoons we have on our website, again, just to remind people about how to put on a gown, how to put on a mask or goggles or gloves, and we also have another one about how to remove them. These are simple little handouts that can be downloaded and be posted in different places in your hospital to begin to review them, as it's a good time to do so now. The interim guidance for specimen collection, transport, and testing. The key points are there again. You can get down those guidelines that will talk about how these specimens should be handled. It's important for you to let your laboratory know that you have someone who is being suspected for having Ebola disease, and those lab personnel need to be adequately gowned and gloved when they come in to get specimens from these people. And after the specimen is being collected, the way the specimen is transmitted to us here at the state and subsequently to the CDC, they have to follow strict guidelines. So we'd like for you to please review those guidance on the website about how to handle and to transport the specimens for testing. Risk assessment to be conducted by each laboratory director, your biosafety officer, and others responsible for determining the potential for sprays, splashes, or aerosol-generating procedures in these patients. Any person collecting specimen from a patient with Ebola should wear, again, the protective garment and be fully prepared with your face shields, your goggles, and everything, so that you don't splash any of this material on yourself. There is also another handout that's on our website about interim guidance for laboratory collection. It's on a one-page thing. It has pictorial in there about how to package the specimen and all of that. So, in conclusion, I just again like to emphasize that Ebola is here, is causing a havoc in West Africa. There are lots of people who are dying. The projection that we've been hearing around range anywhere from 25,000 patients by the end of November to some astronomical numbers by early next year or so. But we're hoping and praying that with the help that the United States, the CDC, the WHO, and other countries around the world are doing in West Africa by building some new treatment centers and sending people there to help with training of healthcare workers, etc., that this thing will be under control. The CDC also has a program where they will be helping to train healthcare workers who want to go to West Africa to help with the outbreak there. These courses are going to be held at Anniston in Alabama, and to help to prepare for people to go there. But we want for you hospitals and infection control personnel around the state to be aware of what is available now, what the CDC has done already, what the Alabama Department of Public Health is doing, and what we have on our websites for your use. So I think we will stop here, and if there are any questions or so, we'll be happy to answer them.
Thank you, Dr. White, and thank you for a most informative presentation and a capsule of all of the material that is available for presentation regarding the Ebola virus. I think that all of us are very concerned about this, and again, the Alabama Department of Public Health is actively preparing as part of our preparation this satellite and webinar today. So do we have questions from the audience, please?
Yes, we do. Thank you, Dr. White, Dr. Landers. This is very good information. The question is, would you be able to speak about the case in Texas? The public health concern in this area would be on how safe will air travel as well as other forms of major transportation be moving forward?
Well, I listened to the press release conference that Dr. Friedman from the CDC gave yesterday afternoon about the case in Texas. From what we know is that this patient, arrived in Dallas sometime around the 20th or so of September, and got ill several days after arrival. That patient was screened prior to leaving Liberia by the procedure that they do, checking the temperature and asking if he was ill and all of that. He did not show any signs of illness, and he traveled here, and it was not until 3 or 4 days after that he got ill. It was also emphasized that the possibility of him having exposed anyone on that plane was very low because he wasn't ill at that time. So they're not planning to do any follow-up of people on the flight. They are very convinced that this is so, and he is now in isolation there in Texas, and the contacts that he's had prior to being admitted to the hospital, meaning people, household contacts and people who he may have come into contact with in the healthcare facility when he presented there a couple of days before he was admitted, all of those people will be identified and checked. I want to also mention here that one of the cases that is being reported that occurred in Senegal was a lone patient who traveled by automobile to Dakar and got sick there and subsequently succumbed. But all the people that he had contact with, they were able to identify them. I think there were 67 of them who they identified, and he was in contact with them prior to getting ill. And all of those patients now, those contacts have gone beyond the 21 days, and none of them got ill. So to me, that's also proof that you have to be sick before you can transmit to someone else. But I think that the folks in Texas have a handle on it, and I am sure that they will be able to have those contacts traced and checked within the next 21 days to make sure that no one else gets it.
Thank you. We have a few more questions. Can you discuss any work being done by laboratories in working on a vaccine?
Well, they again have started some vaccines in normal human volunteers. They've been placed on the fast track within the last month or so, and the plan is that hopefully there will be a lot of fast tracking, that those vaccines can get into phase 3 and 4 trials quickly so that they could be available for use in West Africa. But right now there are no known vaccine that has been approved for the Ebola virus disease, but there are some in the works.
Thank you. Another question, why isn't Ebola considered contagious via respiratory route, given that it is contagious via saliva and one can cough or sneeze?
Well, when you say respiratory route, that's why we have patients in droplet precautions also, and that will cover if someone sneezes or coughs, but it's not airborne like tuberculosis or measles or smallpox or some of the other viruses that we know that are airborne. So contact and droplet precautions are one of the areas in which we say that, yes, we should put patients in droplet precautions when we suspect them to have Ebola virus, because that will take care of sneezing or coughing.
Can you explain in more detail what kind of room can be used for isolation of a patient?
Well, we've talked about having a patient placed in a private room, not a semi-private. That means the single person will be in that room. It should have a private bath. It's not sharing the bath with anyone, and and it has a door that opens out into a hall or so, and I think those are just, the things that you need. It's not you don't need a negative pressure room. You don't need an airborne isolation room. Just a private room with a private bath and not sharing it with anyone else. And of course, monitoring anyone who goes into that room needs to be properly donned with personal protective equipment before even the cleaning folks, anybody who go to clean up the bathroom or whatnot needs to be properly dressed.
And how soon can this room become available for another patient with the Ebola patient discharged?
Well, if you use your cleaning activity after the patient has left the room, making sure that you do a good terminal cleaning, that room should be available for another patient pretty soon, because the material that we use to wipe down and clean a room after a patient has been in there who has been on, say a patient who had C. difficile or something like that. Those kinds of cleanings will also suffice for someone who's been in a place with Ebola.
Dr. White, would you be able to take a phone call? We have a phone call.
Yes. Go ahead.
Yes, I was calling from New Jersey to see how long the virus survives on surfaces.
Well, the virus is not known to survive a long time on inanimate objects or surfaces. We know that when it's in dead bodies, a patient who is not, completely decomposed, or so you can get it from there. But if it's on a surface, a dry surface, inanimate objects or so, it is not known to survive any long period of time.
Thank you very much. And can we go back to the question from the audience, please?
At this time, we have no further questions via email.
Okay. Are there questions from the audience?
Yes. Dr. White, I would like to know specifically with the type of rooms. I've heard that you have to make sure that curtains and other things are removed from, like, the room if you isolate them. What should hospitals do to make sure that they do have an appropriate room available and ready? Since there is the issue of environmental and discarding certain things. Could you give us a few more details about exactly how that needs to be handled and what we need to do to make sure that room is a bit ready for that isolation?
Yeah. Well, I agree that having a room with curtains would not be, very advisable, because again, it's just going to be a private room. There's not going to be anyone else in there that you need, a curtain to sort of separate them or anything like that. The least amount of material that you can have in there that can be contaminated or so would be, likely good. You don't want like furniture in there that, is like sort of that can be soiled, and whatnot, that cannot be easily cleaned and wiped down and all those kinds of things. So you really want to just have a basic room with things and equipment and supplies in there that can be appropriately cleaned. Otherwise, if you have some, like a carpet or something inside the room that can be soiled and not get cleaned, that will not be advisable.
Other questions from the audience? We have a couple of questions that have been posed actually prior to the discussion, and really to just get a little more of your insight on this, Dr. White. First of all, in talking about hospital preparedness, and we went through the documents that were available for this, there are many expert references out there, but if you could point to where you think hospitals can go for the most immediate guidance in terms of how to manage this, what would you say would be the quickest reference for this?
Well, I think the quickest reference would be the CDC website, the CDC Ebola webpage. It's it's very easy to navigate. Well, it has a lot of material in there, but there are some highlighted areas on the left side of it where it has broken down into topics like for healthcare providers, for laboratory, for airline crews, for, all of these things. And it has a specific place for hospital, for environmental control, and all of these things. So the information is there. The recommendations or the guidance are lengthy. They are wordy. They are very inclusive. And I think that those the material will be helpful. The Alabama Department of Public Health webpage also has that information that if you went to that page, you will be able to get some of that information that we have incorporated into our webpage. Again, that checklist for the hospitals that I mentioned to show whether you are ready, what you have you completed, what you need to do, and what you haven't done. That is going to be another very good source because it goes through all the different things that you need to do in preparing, like in your triage area, in your emergency department, what kinds of questions you want to have on that form. Having PPEs, some people have kits, PPE kits are available in strategic areas in your hospital so that you don't have to be going, here and there trying to find a gown or glove or so, having them ready, at a particular place, at this time. Letting your lab know about, what they can expect when you're called, to the emergency department or so to come and, have a patient tested. All of that information is there for hospitals. We also have some information there for clinicians, people in the community who have patients who have traveled and come in, and the patient, call them or show up to their offices and say, I'm sick. I was in Liberia, a week ago. I mean, this has happened. It will happen. And so you need, that information is there, but what the clinician should do and making sure that your patient, call you ahead of time to let you know that they have this so that you can make arrangement out of for transportation, especially if the patient is symptomatic. You don't want them just putting them in the van and bringing them, to the hospital. Those patients EMS needs to be called to be dispatched to the areas, so that they can bring them. The emergency room needs to be notified so they can be ready to get that patient into an isolation room as quickly as possible as you are working them up. I think there are many times that at least that part of it may be done, but then when we get to the part where we are taking the history and finding out whether the patient meets the criteria to be tested, you'll find out that majority of the times this patient was a low-risk patient anyway. Maybe they have a headache, maybe they have fever for something else, and that you may not need to continue all of this thing that we're doing. I think in Alabama here we have had probably over 13 or so inquiries that come to the state to determine whether somebody needed to be tested. And I don't think we have had anybody who met the criteria here in Alabama to be tested for Ebola virus disease. Many of these patients, again, ended up having something else. I know I had 2 patients that ended up having malaria. But I tell you, when you get that call from a patient, from a physician in the community, say, I've got someone who just came back from Liberia a week ago, and he's in my office, and he is sick, that will, cause some hair to stand up on your head. But again, the CDC site is very, very helpful. The ADP site is also very helpful. So please, let's get familiar with them, and let's use them.
Thank you. Dr. White, we have another telephone question.
Tallapoosa County.
Go ahead, Tallapoosa.
Hello. We were wanting to know how long is the turnaround time on the confirmation for the lab for Ebola?
Well, taking from the experience of what happened in Texas the other day, I understand from what I read, so that it probably took about 2 days from the time they got the sample and send it to the lab to do the test and get back. So that's what I'm thinking about. We're hoping that time can be shorter because the CDC has now some laboratory networks across the state, across the country that have been sort of repped of to be able to do the testing, in a particular region, that everything will not have to come to Atlanta to the CDC there. So when more of those labs are available, I'm anticipating that the time period will probably be shorter. But right now we're looking at 2 days.
Thank you very much.
You're welcome.
Thank you for the phone call. Is there an additional question from the audience, please?
That have come in.
Thank you.
One question is for you to explain in a little bit more detail about what it means to be sick, to be infective. Does it mean clinical manifestation or a simple fever, et cetera?
Well, again, the clinical manifestation of someone who has become ill with Ebola virus disease will be that they have gotten fever and they have gotten some of the other symptoms that we talk about, headache, abdominal pain, nausea, vomiting, muscle ache. That New England Journal paper that I referred to that came out recently had about maybe 10 or 12 or so different symptoms and ranking them into how, many things. So it's possible that many of those symptoms may mimic some other problem. But again, so having those symptoms have to be associated with the fact that you were in an endemic area, you had contact but with someone who was ill, you visited someone who was ill, you helped to care for someone who was ill with Ebola. All of those things have to go together because those symptoms, they are symptoms of any viral infection, any systemic infection or so. So if you've got those symptoms and you've been to the area, then you would be someone of interest, okay? Again, that's fever. Everybody's talking about fever because fever is one of the things that they say happens really quickly. And depending, again, on how much exposure you've had to someone with the disease, I mean, if you lie in bed with the sick child who, been vomiting and, cleaning their diapers and doing all of that, and that child, well, you're going to get sick probably in the shorter period of time, 2 to 3 days or so, you're going to get sick. But if you, inadvertently touch an object or so and went to your face, and one time, and then it may take a longer time. But the fact that, well, yes, you were exposed or you were around someone with the disease, so one of the patients that I had to evaluate in Tuscaloosa, the patient again was in Liberia, but this patient worked in a mining area where they were doing mining. They had a no-touch policy at the mine. Everybody had their own shovel. There was no one had been sick in the region, and all of these different things. And then the person did not take anti-malaria prophylaxis and all of that. So we sort of easily said, well, he was there, but no contact with a case and whatnot. And so we started to look for something else. And then the CDC, when we talked with the state and told us, they said, no, that's not a person of interest. So again, those things have to go together. The clinical epidemiological exposure plus the systemic illness.
Thank you, Dr. White. We have another phone call.
This one's from Texas.
Okay, go ahead.
Go ahead.
CDC recommending proper disposal and handling of a human body after death from Ebola.
Did I understand the question to mean how will you manage the disposal of a body of someone who's been infected with Ebola? Well,
yes, I understand that Africa is having some issues with the bodies. So if you could tell us what we will do in the United States.
Well, I think there are some recommendations and guidance for mortuaries too on the CDC website about how those should be handled. I mean, the mortuaries should be made aware of that and whatnot, and they have their, think about what they do. In Africa, it is a big problem there, and they are now trying to do. They're trying to do cremation is one of the forms in which they're taking care of bodies over in Africa, and otherwise they have burial teams and people who specifically will come out to to the home and get the body, and they put them in, wrap them up in impervious material, and they have people who go to the grave and bury them and all of that. But here there are some guidances for mortuaries from the CDC, and I think we should go to that and make ourselves familiar with that.
Thank you. Kelly, are there other questions?
Yes. These two questions go together. Can the patient's body fluids like vomit, urine, and stool be flushed down regular commodes? And then is there interim guidance available for water treatment plants to accept the wastewater? They're worried, they're concerned that the normal operations may not disinfect adequately.
Well, I think, not really researching it or so, that it will be safe to flush stuff down the commode. If someone went in the bathroom and vomited in there, I mean, you can't go and pick it up or stuff. I mean, you just flush it down. Now, about whether the wastewater treatment plants or so will be able to decontaminate that, I'm of the impression that they probably will be able to do so, because the methods by which they do, we know, will kill most microorganisms there. But I would probably have to do a little bit more research about that before I, put my, thing down on it. Maybe someone else knows about that and can answer that question. But I think it will be safe to flush it down the toilet.
I believe there is some interim guidance on that on the CDC's website. Dr. Mack, would you comment on that, please?
Actually, there are recommendations on handling it on the website, and the information it basically says that once they're being identified and they know specifically that this patient is positive, there are certain ways that with the system, how it goes into the waste system, it doesn't just go, there are special means of handling even their bodily fluids, including the feces. And I don't remember, but I would recommend everyone to go take a look at it.
Yes.
But they do have recommendations for someone that's been diagnosed with Ebola on specifically how to handle their body fluids.
Okay. Thank you, Dr. Mack. Other questions, please?
The mortality rate in Africa is quite high, as you presented, and can we expect that cases in the United States will not be so tragic as our healthcare practices are so much more aggressive?
Oh, definitely. I again feel that the mortality rate in industrialized countries will be much lower than what it is in West Africa. Again, because of the healthcare infrastructure in those countries that have broken down. There is no possibility of anybody being in a private room in Africa, and they have wards, and you see people lying in camp beds, right next to each other, and that is always a concern that you certainly don't want to just put someone who is quarantined or not infected in an area like that. Some of the other experiences, even in Nigeria, where they had that one case that came in and they ended up having over 900 contacts that they had to investigate for that one case. The mortality rate there in Nigeria was much lower than in the rest of the region now, because they really went out, aggressively to curtail it. So with the treatment that one is able to get in the hospital here, the rehydration, the restoring of blood, or having them available with oxygen and all of that stuff, will certainly improve the survival rate of anyone who is infected here.
And this is a comment that is requesting a response to. If a person has symptoms and travel history, but is positive for malaria or another illness, that does not mean that they cannot also have Ebola.
Yes, that is true. And I think, again, that will be, if you're talking to them and trying to elicit the history from them about whether they've had contact with someone or, participated, and that may be a person of interest that you may want, again, to test. If they say, yes, I had, contact with someone, or I know someone who died, or something like that, then whether you check them for malaria and find that, I think that person will still need to be tested for Ebola.
Thank you.
Thank you, Dr. White. We have an additional phone call, I believe.
We do, from DeKalb County.
Go ahead, DeKalb.
Yes, we're wanting to know if this is an asymptomatic and a person can be a carrier similar to the flu virus.
No, ma'am. If you have been exposed to Ebola and you do not have immunity, meaning you haven't recovered from it in the recent past or so, and you become you will become sick within 21 days if you've had insignificant exposure. So it's not something that the person is going to harbor and sort of have a subacute illness here and and there, and go on to continue to be a source to transmit it in the community. I've not heard about that in any of the previous outbreaks that have been reported in the past.
Thank you, Dr. White. Could we return to questions from the audience, please, in the last few minutes?
And this question comes from the Department of Health in Texas. Have you witnessed or heard of any examples of social stigma associated with those potentially exposed either in West Africa or abroad?
Unfortunately, yes, I have. I haven't witnessed it personally, but I read about the stories of several individuals who have, recovered from Ebola in Liberia. There was a particular a physician who contracted Ebola. He went to the treatment center early. He got treated, and he recovered from it. And he went back to his place of residence, and the people shunned him. And he wrote in his paper. I mean, in the letter, he said, "I wish I had died," because people now, they don't want to touch me. They don't want to come around. They don't want to shake my hand and all of that. So that really touched me when I read that about what this guy said. And so now that there are more survivors who, as the outbreak is going on, they are incorporating, trying to use some of the survivors into some of the outreach into the community to show that these people are not infected. I think some of the agencies that are working in Africa, when they have someone who has recovered from the disease, when they take them back into the local community, they take pictures with them, hugging them, and standing by them and shaking their hands and all of that, so that they can see that, okay, if these healthcare workers, if these expats feel comfortable enough to do this with this person, then yes, we know that, okay, the person is free. And a lot of the survivors, again, are coming back and saying, well, we want to help because we have succumbed from this, and we understand that the chances of us getting reinfected is low. So it's not that, well, they just don't go in there with without PPEs and whatnot. We still try to protect them, but their chances are much lower. But yes, there is stigmatization, and people don't want to affiliate with these survivors.
Additional questions from the audience.
There is some additional comment on the environmental survival of the virus, explaining from the CDC website that the virus can remain viable on solid surfaces over a period of days with the concentrations falling slowly. However, there's limited studies on this and very little information on the transmission of the virus in this manner to a person.
Right.
Thank you. In the last couple of minutes, are there additional questions that we can answer before we close?
I don't have an additional question, but I wanted to make sure that people understood that we will have additional information following the webcast. Maybe not today, but it will be on the website. And we will try to capture as much as we can the Q&A so that it'll be there. Okay.
Thank you very much. Any closing questions? If not, I would like to thank everyone for the participation today. I would specifically like to thank Dr. Albert White for bringing his expertise and his personal passion for this to the Alabama Department of Public Health, so that we can all take this information, we can continue to educate ourselves, we can continue to learn about this virus. Let me remind everyone participating today to please go to the website and complete the evaluation in order to receive continuing medical education for this. And thank you very much from the Alabama Department of Public Health.